Hello, everyone. My name's Toby Kohler, coming at you from Rochester, Minnesota, with my good buddy Matt Ziegelman. Go ahead and introduce yourself there, Matt.
Everybody, yeah. Hi, my name's Matt Ziegelman, also from Rochester, Minnesota, and looking forward to participating in this evening's webinar.
Yeah, so I see we got about 15 people logged on. We'll give them one more minute. And the goal of today's seminar is to cover high-yield priapism changes to the recent guidelines, hopefully cover a lot of practical stuff that APPs would find useful. And if you have any questions, you can always drop them in the chat, and we will try to answer those in real time. And I'm going to fire up a couple poll questions here to kind of get an idea of which direction we should go. And max, this will be 1 hour. It will not be longer than an hour. Everybody, we will try to get, be done in like 40 minutes. But if there's a rigorous discussion with a lot of robust questions, of course, we'll stay on as long as we need to. At the end of the seminar, you'll see both Dr. Ziegelman's and my emails for future correspondence. Never hesitate to let us know. By way of housekeeping, we have to thank the SMSNA and Endo for sponsoring this APP webinar series. This is the first of 2022. 2021 was a super successful year for the webinars, and those are actually all viewable in the members section of the SMSNA website, so you can go back and check those out. And without further ado, I'm going to launch a couple poll questions, and so answer these in real time, and this will really help us kind of guide the discussion. So I'm going to launch this guy here. And the first question is, my personal involvement and interest with priapism as an APP has been either theoretical, I've never seen it, but interested. I've seen priapism patients in follow-up, had to treat in clinic, or I've witnessed an operation for it. So far, we've got 5 answers. Matt, are you seeing these answers or just me?
I'm not. No, I'm just seeing the question.
All right. Well, we've got, maybe if I can let you guys know how it's breaking down. So we got 12 answers, and about a quarter of the group this is theoretical. 2 people out of 12 respondents have see these patients in follow-up. 4 have treated priapism in clinic, which is very interesting. And then 3 of the 12 have actually witnessed an operation. So we got a really nice split, and that's going to help guide the discussion. So I'm going to end that poll. And I can share the results. There we go. So can you see those results, Matt?
Yep.
Okay, perfect.
We
So
can.
there you go. I will not have to give a beautiful auditory summary for the next one. Okay, let's. I'm going to go to the next poll question. I'm going to stop sharing that. Question. Main objective.
Yeah, and I can see that one too.
Perfect. So main objective for today's talk of the 17 peeps on the line is learning pathophys, diagnosing priapism, treating priapism, or preventing future priapism.
I wish you had an all of the above here.
Yeah. So we're getting the vast majority are focusing on treatment. And we got 13 respondents. And I'm going to close the poll in 3 seconds. 2, 1, and you've been locked out. So there is the results, which I'm trying to share. So we got some interest in pathophys. About 50% want to get into treating and then prevent future priapism. And that may be good for patients who have like stuttering priapism, for example, which is a really tough condition to treat. All right, next question. It's a single choice answer, but there is a kind of all the above option. Who has treated patients with, in real time, low flow, high flow, stuttering, or more than one of the above? Trying to get an idea for how many patients, how many providers deal with stuttering priapism. At least one. Very good. So I think we're covering all the bases here. Okay. I'm going to end that one. A couple more questions, then we're going to launch into some epic priapism information. Okay, so here's a interesting. This is an opinion question. What is the most important part of diagnosing priapism? Of course, we can always choose more than one option, but if you can only have one thing, one test, penile blood gas gets an answer. History.
This is a tough one.
Yeah. Ultrasound. I think these are all legit answers. No MRIs. That's good. Your APPs are doing a good job of saving healthcare costs.
Yes, cost-conscious care. That's excellent.
So most people say history, and I tend to agree with that. How about you, Matt? If you could only have one, what would you get?
Yeah, I don't know. I was looking at that, thinking if we're differentiating it, penile blood gas would be helpful as well. But it always go back to the history and examination.
I'll share the results real quick. Okay, that's pretty cool. And then I'm going to stop sharing again. We're going to. Here's a good question. This is where you can show how smart you are. This is a take-home message. The shortest length of continuous priapism, that is to say, you are sure this man has had priapism for X amount of time, that always results in ED. In other words, the penis is a foregone conclusion. How long does it have to be before we can send it in for this man's penis and already move on to very aggressive options? We've only had 3 answers so far. Oh, this is good. We may actually get some learning as a result of the seminar here. So I'm going to close the poll down. And I'm going to share the results. So in classic question format, I made it in increments, perfect increments of doubling time, if you will. And spoiler alert, the answer, according to the guidelines, about 36 hours. But the problem with that 36-hour mark is, like, you never really know, is it truly continuous, or have they had this intermittent resolution? Did some outside ER actually treat the priapism? But the answer is 36, but I put 32 in there just because I didn't want to give it away because of the test question format.
Yeah, you tricked me. I was thinking, I thought it was 36, but I had to pull up the guidelines just now.
Yeah, well, there we go. Okay, excellent. And then let's go to the last poll question. True, false question. The counseling for potential long-term side effects of erectile dysfunction is the same for both untreated and treated priapism patients. True or false? Oh, it's a dead heat here. Oh my, it's we got 13 answers, 14 answers, 15 answers. Clearly there has to be a winner at 15. So I'm going to end the poll quick. So false got the most votes. And I think this is a little bit debatable, but the answer that I was after was true. Because my opinion is that when you're counseling patients that come in for priapism, if you do nothing, clearly they're at risk for erectile dysfunction. And if you treat them aggressively, they're still at risk for erectile dysfunction because they had a priapism of X amount of time. And then sometimes the treatments you do are going to induce problems with erections in the future. So I think the safe bet for everybody on the call is to say, listen, no matter what we do, we were at risk for getting problems with erections, but we're going to try to minimize that risk by doing something now and potentially help with your pain as well. So a little bit of a trick question, but I think it gets the point across. All right, I'm going to close down these polls. Closing down.
Thanks everybody for participating in that part.
Yeah, I appreciate that. And we're going to go into the share screen version.
And I put a little message in the chat, but if anybody throughout this, I'm going to try to monitor the chat. So if you have any questions, comments, need clarification, feel free to use that.
Okay, so again, I'm Toby Kohler. That's Matt Ziegelman. Those are our Twitter handles. Thank you for Endo and SMS for putting on this series. And without further ado, we're going to dive into these glorious slides. There are conflicts of interest. We're going to review the Priapism updates, and there's the investigators that helped put these together. And the scope of this particular guidelines is for the acute priapism patient, and the index patient is the guy that comes to you with 4 hours of priapism. And there are 53 slides in this talk, of which I've hidden more than half, so don't worry. We're only going to include the good ones. And there's a future priapism section, which is written, it's been edited, it's been approved, but it's going to take a while to hit the publications on stuttering priapism and non-ischemic priapism, like high flow. So that is headed your way over the next several months, but we will touch on some of that with today's talk. All right, take it away, Matt.
Total noob move. I just started talking with my computer on mute. Sorry, everybody. All right, so yeah, this is a update, a much needed update from the previous guideline, and there are several additions that have been extremely useful in guiding clinical practice, and that's for people who are more or less experienced. So several of the new additions to this guideline include that there are now recommendations regarding the type of imaging that can be considered. So examples would be in ultrasound, if you sort of have equivocal exam findings, CT scan or an MRI. We'll say CT is probably has a lot less utility. MRI would be for patients where you're sort of looking for evidence of fibrosis of the penis. The guidelines include more definitive statements regarding what lab tests you should consider, essentially recommending that in the setting of an acute presentation to an emergency room, that we have a urologist or urologic specialist who is involved in the therapy, discuss conservative therapies, and basically that these should not preclude moving forward with the treatment pathway that we'll talk about. Importantly, as Dr. Kohler had mentioned, counseling for risks of erectile dysfunction and some of the complications of the interventions we use, we'll talk about those. But certainly one of the big take-home points is just when you see a man coming in with usually ischemic priapism, you really want to counsel them about the potential risks for erectile dysfunction, regardless of what intervention you carry forth with him. There's recommendations about when to use phenylephrine and irrigation that we'll talk about, and then certainly we'll talk in more detail about some of these more advanced interventions, and it'll be a fun discussion with some good pictures.
Very good. And if people are thinking on the audience, like, who would ever get a CT scan for priapism? That's mainly dealing with high flow priapism. If you're getting like CT angiography to cinch the diagnosis of a high flow person, that's probably the only time you'd actually do that. Sometimes MRIs are useful to see if the penis is dead or not, but it's almost always ultrasound if you're going to get imaging. All right. So I'm going to advance the slide here. Whoops. All right. So statement 1, in patients presenting with priapism, clinicians should complete a medical, sexual, and surgical history and perform a physical exam, including the genitalia and perineum. In the vast majority of cases, the difference of acute ischemic versus non-ischemic is made using history and physical exam only. And, does it hurt or not? And is the entire penis hard? Like, is it 11 out of 10? Or is it a kind of a softy partial erection? And, typically the high flow priapism is painless because you got excellent blood flow to the penis. Whereas a low flow priapism, the one that these guidelines typically deal with, cause pain because you're having a heart attack of the penis. You have low oxygen going out to the tissue, and the smooth muscle of the penis is dying. Some people describe priapism as a compartment syndrome of the penis. And essentially what you're trying to do is relieve the compartment syndrome. But yeah, ask good questions and you'll be able to figure out what's going on. All right. Go ahead, Matt.
Okay, so yeah, so the second guideline is about a corporal blood gas, and this kind of comes back to one of those prompting questions that Dr. Kohler had brought up. What are the most important aspects of the evaluation? And as we mentioned, history and physical, very important, but the corporal blood gas can essentially differentiate high flow and low flow priapism when in doubt, and essentially if you're going to move on to more invasive treatment, the guideline recommendation is that we should obtain a corporal blood gas just to document those findings. What we are going to see on a corporal blood gas in a patient with low flow ischemic priapism is low oxygen and high CO2. So it's a hypercarbic state. That's essentially ischemia of the tissue. And so we will also see very acidic blood gas, which again is consistent with metabolic acidosis, which we see with ischemia. So that would be a pretty classic finding, and it is in this classic setting of ischemic priapism, it's usually pretty obvious. You get that blood gas back, and pH is low, the O2, PO2 is low, and the PCO2 is very high.
Yep, and that's like the most common question that urology residents get on like their in-service is always some blood gas findings. All right, when do you have to get it? There's some debate if you have to get it or not. Most of the time, you're going to get it to convince yourself that indeed this is a low flow. But I think, is it absolutely necessary? I don't know. But the guidelines say you probably should get it. Where do you not need to get it? Well, let's say you give a guy an injection in the office and you induced a priapism from giving him Trimix when you're doing a penile Doppler. Clearly, you're causing a low flow priapism there because they're starting to get pain, the erection go away. You don't need to get a blood gas. If they've had ischemic priapism in the past, and this is a recurrent type of guy, it's a sickle cell patient who bounces every week back to the ER, don't need it. Or if the diagnosis is very clear. So what the guidelines typically try to do is always provide a little bit of wiggle room as we go. And I'm going to open up the Q&A here.
Yeah, there was a question, and this is a great question, and I was hoping this would come up. What is the real influence or risk of PDE5 inhibitors and priapism? So this question gets asked a lot, and we think back to I think it was a Cialis commercial where the couple is sitting in the back, this beautiful backyard in clawfoot bathtubs, but outside, and they're overlooking this beautiful scene. And then it says, if you have an erection lasting longer than 4 hours, your dogs agree. So it's a classic surgeon look there too. Party on top, business on the bottom. So anyway, sorry, I digress. Essentially in the absence of a predisposing risk factor, what is that? That's sickle cell anemia or sickle cell trait. That is another blood dyscrasia. That is abusing drugs, essentially cocaine, right? That'd be a classic, or methamphetamine, or using psychotropic medications. Trazodone would be an example. Some type of risk factor for ischemic priapism plus a PDE5 inhibitor. That is really where you're going to see that risk for ischemic priapism. In your patient who's otherwise healthy and just has organic erectile dysfunction, we just do not see that. It's important to counsel patients to be on the lookout for it, but we just really don't see that in practice.
Yeah, I agree. Most of the data, when it looks at the comparative cohorts, is not an increased risk for priapism. Indeed, for stuttering priapism, sometimes we try to give men PDE5 inhibitors to reduce stuttering priapism episodes. Something about downregulating the receptor sensitivity. At the end of the day, I don't think it increases the risk for priapism as opposed to penile injections, which are like the main cause which are induced by urologists. So we got another question rolling in. Does the duration of sickle cell anemia have any relation to priapism? That question's, I'm not sure what you're getting at there, but I guess the longer you have sickle cell anemia and the more the worse it becomes, the more progressive it is. I think the higher likelihood that you're going to get sickle cell crisis, obviously, and then sickle cell crisis is what puts patients at risk for getting priapism. They just have poor blood flow to all their periphery. Okay, we'll move on. Clinicians should use penile duplex ultrasound to help cinch the diagnosis of acute versus non-ischemic or high flow priapism when you're uncertain. And if you've ever done a penile Doppler in your office, which a lot of you guys and gals have done, when you see nothing, no flow in the penis, that is priapism. And then when you see a ton of flow, that is high flow, and you don't need to worry, and it's not an emergency, and you can send them home and take care of these patients in a non-emergent acute setting.
And one of where this comes into a lot of utility would be, let's say that you see a patient and, we're jumping ahead a little bit, but you administer your treatment and they have a lot of swelling on their penis, and you don't feel confident that they're fully detumesced. They still feel like, is this an erection or not? Sometimes these patients do have some persistent tumescence, but the essentially ischemia has resolved, and this has some utility there. You can do an ultrasound and verify, hey, they have flow, and you feel more confident that you've treated them.
That's the bane of the urologist's existence. You do a shunting procedure, and the next morning the guy still has pain. You're like, oh man, is the priapism back? That's when ultrasound can really be helpful to help determine, do you have to do something else, or are you still good? And that's a very common scenario, that if you're monitoring patients like in the hospital post-op as APPs, then this is where this tool, don't forget about this tool to help differentiate, in addition to a repeat blood gas, obviously. All right, Matt, take it away.
Okay, so this is essentially the example of a blood gas and what we would find. I'm sorry, not a blood gas, physical examination. So when we're differentiating ischemic priapism, Dr. Kohler had mentioned this previously, but things you want to look out for on that examination that would suggest this is ischemic priapism. You usually see that fully rigid corpora cavernosa, so the erectile body of the penis, essentially that 10 out of 10 erection rigidity. These patients come in with significant amounts of penile pain because of the ischemia, and that abnormal cavernous blood gas, that's where you're going to see that acidemia, or acidosis, I should say, and the high CO2, low oxygen concentration. These patients, depending on their medical history, may have a history of blood abnormalities, as we talked about, like sickle cell anemia. They may have been using either appropriately or inappropriately the medications that we prescribe, right? So this is that patient who has intracavernosal injections, and we say start at 5 units, and he says, well, 5 units didn't work, let's try 50 units, and ends up in the emergency department. And if you compare that to non-ischemic priapism, essentially these patients tend to have tumescence, but not a rigid corpora cavernosa. They're less likely to have pain. Their blood gas would look more consistent with like a venous blood, and they are less likely to have those concurrent medical comorbidities. They are more likely to have a history of penile or perineal trauma. So, I think of a young kid I saw during fellowship who took a skateboard to the perineum and came in with partial tumescence that had been ongoing, and he was very comfortable, but he actually did have non-ischemic high flow priapism as a result of that trauma. Let's see, there is a comment here about how when patients have ischemic priapism, I like this. I think this is a Dr. Kohlerism. You sort of think about, why is the corpora so rigid? Essentially, with the trapping of that blood and the inflammatory cascades that have been started, it becomes like a malleable implant. Which is a really nice way to think of it. And like he mentioned previously, this essentially is a compartment syndrome. And the goal with treating ischemic priapism is, one, obviously we want to optimize their pain control in the immediate setting. we want to get them more comfortable, but we also want to optimize their sexual function in the long term.
The other reason I try to draw that analogy that it's just like a malleable implant of the penis is because when I was a resident, I used to think that priapism would put patients at risk for their penis to fall off, like getting like penile gangrene, which doesn't make any sense because there's like a lot of different blood flow to the penis other than through the corpora. But if you think about, when we put a malleable implant in patients, their penises don't fall off, right? It's like, it's not the end of the world. We're essentially we're making a priapism with a device instead of a priapism with, stagnant blood. So it's not the end of the world to have priapism, but that tissue is going to die if we don't treat it. And but these are the only two things we're essentially managing: future sexual function, whether it's erectile dysfunction or the risk of Peyronie's disease we get from scarring, and pain. And other than that, we don't do anything with priapism treatment. So just a different way to look at it. All right, I'm going to go to the next slide here. So here's a classic picture of the initial evaluation and management. You get your history and physical, you get your Doppler. It's considered an emergency if it's low flow, it's painful. And essentially, you get these corporal blood gases. And I do like this picture here where it has like one butterfly needle coming in on one side of the penis, and another butterfly needle coming out the other. And this double butterfly approach is one way to treat priapism. So you use one to inject either, phenylephrine or whatever agent you're using. Phenylephrine is best. And then you use the other butterfly needle to pull blood out of the penis. Your goal is to get that crankcase oil out of there. It's dark blood. It looks like thick motor oil. And you pull that out, and then you inject more phenylephrine and sometimes normal saline on the good side, or the side where you're putting it in, and you just kind of work it through until you manage to pull all that stuff out of there. Some people hang an IV bag in here, but these butterfly needles, the bigger the better gauge, they just stay in there. Sometimes you can do a penile block before you do this, and this is a way that some people manage the priapism.
Yeah, I think the penile block, if you're able to do that, to get facile at giving some local anesthetic at the base of the penis into that neurovascular bundle and circumferentially, that makes a huge difference, because then, you can use as big of a needle as you want, and you can squeeze the penis as aggressively as possible, and they're going to tolerate that really well.
Yeah, and interestingly, when we induce priapism with Trimix in the office or whatever agent we're using for penile Doppler, the penile block makes them D2MS often just by itself. It's like somehow you disrupt the nerve signaling, the cascade, and that makes the priapism go away. The other thing to remember is that, before you stick the needle in these guys' penis, you need to pull out the biggest needle you have, like one like this big, and they're like, I'm going to stick this in your penis. And you just try to scare the bejesus out of them. And that way you will make that patient release adrenaline in their adrenal glands, a different form of phenylephrine, right? And then sometimes the priapism goes away. So fear is an excellent way to get rid of priapism. And that's why performance anxiety is a real thing, right? If you are running from a bear and you've got a lot of adrenaline, clearly the body is trying to be intelligent and is going to shunt blood away from your penis, right? You don't want blood in your penis when you're running from a bear. You want blood going to your brain so you can think, escape. You want blood going to your big muscles so you can motor out of there. So that's why adrenaline is the most powerful anti-erection drug that we have. And that's why we inject phenylephrine. And that's why performance anxiety is real. And so sometimes you can scare the priapism away from the patients. That is a real phenomenon. All right, next.
All right, my turn. All right, so the additional testing that can be used to help determine whether this is ischemic or non-ischemic. There are a variety of tests, and we talked about, you can order an ultrasound. We talked about the corporal blood gas plus or minus. There are some additional tests that can help determine the potential etiology underlying this condition. And so, for example, we'll pretty routinely order a urine drug tox screen, right, to screen for drugs of abuse, which often underlie that patient coming in with sort of the idiopathic ischemic priapism, usually a CBC, an electrolyte panel. With the CBC, you're looking for some type of undiagnosed blood dyscrasia. On occasion, you'll see this as a result of some type of acute crisis, for example, in the setting of leukemia or lymphoma. And then even some of the more rare blood abnormalities. But essentially, none of that testing should delay you from the interventions that were just mentioned. That none of this should delay you from moving forward with the definitive treatment to bring down the priapism.
And the practical side where we see this most often is if this is a sickle cell anemia patient and they're doing a bunch, thinking about exchange transfusion and they're ordering sickle cell smears or whatever it is you order in that time. So that cannot delay your treatment, right? Because time is tissue with true ischemic priapism. So you want to treat them as soon as possible. A question has rolled in. It says, what is the prognosis on erectile function after ischemic priapism? Do really intravenous injections work? So I'm not sure about the intravenous injections, but maybe they're talking about intracorporeal injections. But if you have a priapism of 4 hours, there is no sequelae. Like if you treat it, nothing bad happens. It's essentially like the difference between having your arm fall asleep and then you wake up in the middle of the night, you reposition your arm and you're fine, or having it pinned underneath your body for like the next week. Yeah, it's going to fall off eventually. So it's just a question of the degree of ischemia and the severity of the tissue injury. And again, after 36 hours, that smooth muscle of the penis that's supposed to relax during erections, bye-bye. It's gone. It's no longer going to work. It's going to become rock hard, and it's not going to support the normal physiologic mechanisms that erections are supposed to have. And so here are some of those examples of some of the adjunctive tests that should not delay your diagnosis.
And I think in the context of if you go back a slide, like the hemoglobin electrophoresis, obviously that plus the retic count, those are going to be looking for a diagnosis of sickle cell that we didn't know about. Most of the patients with sickle cell anemia, we know that diagnosis, but they were diagnosed earlier, and oftentimes these are patients that come to the emergency department on a not infrequent basis. That being said, for your patient with idiopathic ischemic priapism, where you're sort of scratching your head saying, why is this patient doesn't have a history of drugs of abuse or psychotropic medications, that's where in a delayed fashion you can get these tests, right? You can get your retic count, you can get your electrophoresis to look for the hemoglobinopathies, but in real time treat the patient at hand.
And indeed, we covered this already, but honestly, the most common things are either we have no clue why it happened, or the dude took trazodone to help him sleep. I mean, that's just classic. We always ask about trazodone, and then it's penile injections, either getting a little aggressive with urologist or APP prescribed or whoever prescribed it dosing, or borrowing it from friends, doing a little experimentation, and then also there's a huge list of stuff that can cause priapism, but often some like drugs like cocaine, marijuana, ecstasy, those can facilitate these events as well. Okay, so give phenylephrine. After, once you get your diagnosis, phenylephrine is your mainstay of treatment. It's always worked better in combination. We'll get to this on the next couple of slides, but phenylephrine is your main treatment for a priapism. What dose should we use, Matt, and how often?
That is a great question. So I believe the guidelines say 100 to 500 100 to 300 micrograms every 2 to 5 minutes. There some variation of that, and keep those, monitor those patients for cardiovascular abnormalities. I will tell you that in practice, for example, if we have an iatrogenic priapism in the office after we're doing a penile ultrasound and the patient doesn't have any cardiovascular risk factors, we will give them 500 micrograms of L-prostadil into the penis, maybe even 1,000 within 5 to 10 minutes, and feel confident and safe about that. But guidelines sort of leave a little bit of wiggle room again, based on the patient at hand and your comfort level and experience.
I'm just answering in the chat here. We had Eric said, I believe there's an over-the-counter analgesic that can be used to help treat priapism. You know, our guidelines they say to avoid these type of things. I mean, you can give them as long as it doesn't delay the definitive treatment. So, you know, Sudafed, ice, exercise, these are all things that may or may not work. Ejaculation is actually a very good choice, right? Because what you're trying to do is tap into the Mother Nature's detumescence mechanism. So ejaculation, repeated ejaculation often will help get rid of the erection when they're still at home. They're calling you, they're like, hey, it's been 3 hours since I had my injection. Once they make it and they actually have true priapism in your emergency room, you're going to give them a dose of phenylephrine, because that is the most effective, quickest way to fix this problem. Let me go to the next slide. Any other comments there, Matt?
Yeah, I think the only thing is if you do encounter these patients in the emergency room, the combination of giving them phenylephrine, but also aspirating out that old blood, like take out that hematoma, take out that malleable prosthesis, essentially, so that when you do give the alpha agonist, that you are giving it to, you know, tissue that's more supple and presumably has you know, vascularity that's going to allow it to dissipate throughout the tissues. So
yeah, if you can only have one, probably the best thing to pick would be the injection. But clearly the outcomes are superior when you use both injection and aspiration, because you get this mechanical blockage of the vessels. And even if you give all this medication, which is trying to get these blood vessels to go back to their normal state and not allow blood in, you can't get it out unless you get the old crankcase oil out of there, whether it's through squeezing the penis or like physically pulling it out. All right. And again, this is kind of the same thing we just talked about. The question that was given kind of preempted this particular slide. And there is a particular guideline statement about what we just talked about just now as well. It's coming up, use combo.
And here's another question about using Sudafed at home. Susan suggests using 120 milligrams and then repeat with 60. And absolutely, I mean, if we're essentially you know, treating a patient with priapism or suspected priapism after intracavernosal injections, if they have a prolonged erection lasting more than 2 to 3 hours, that's usually the first step, is to do things like we mentioned, use ice, ejaculation, use Sudafed. But if they're approaching that 4-hour mark, we would not have them try Sudafed and then come in, because that essentially is going to delay the most definitive intervention, which usually beyond 4 hours, we are looking at these alternative treatment pathways.
Yeah, indeed. It's kind of like taking a aspirin under your tongue when you're having chest pain. It's like, if you're having chest pain, you're definitely going to go to the ER to get your heart attack fixed. Yeah, sure, if you want to take some adjunctive nitro or put aspirin to help treat it ahead of time, great. But it cannot, the bottom line is it can't delay you getting to the ER, because again, time is tissue. So you don't want to let it delay what you're doing. All right, I'm going to go back to the slide. So again, this is in priapism greater than 36 hours. It is unlikely the acute ischemic event will resolve with local aspiration ICI therapy and with phenylephrine alone, and the penis is probably dead. So once you get to somebody who has 36 hours of treatment, most of these treatments you're going to try are going to be heroic. And if it's a definitive 36 hours, then you might not need to do anything. You'd be like, oh, time for a penile implant in the future. We don't need to shunt you because we can't save anything. But in reality, it's very difficult to prove that they had 36 hours of continuous priapism. We got a comment coming in that one of my urology colleagues prescribes phenylephrine for patients to self-administer at home. I'm hesitant to prescribe this. What are your thoughts? Well, it is in the previous guidelines. It is certainly a reasonable thing to do. Phenylephrine itself is not unsafe. It's like an EpiPen for the penis, but patients have to be trained how to use it properly and safely. And it's probably a better principle to help avoid the recurrent priapism. If it's coming from repeat injections, can we use a different formulation? Can we back off on the dose? Can we stop combining with PDE5 inhibitors? But yeah, no, home self-administration is sometimes the most practical, cost-effective way to treat patients with recurrent priapism. But these are the guys that may benefit more with like a penile implant or malleable implant, because then they're not coming to the ER every 5 days when their home injections aren't working. And there are truly some patients that just bounce again and again and again, and you get to know the patient's first name. And like, oh, another phenylephrine dose for Larry. So, okay.
And then one of the classic presentations where we might use that too, like a young guy who's post prostatectomy, who had excellent erectile function before and does not have vascular disease. That his blood vessels are working well. It was a neuropraxia from the prostatectomy. Sometimes those guys, they get a whiff of intracavernosal injections and they have an erection that lasts hours. And we're sort of hopeful that this is a temporary phenomenon, that they're going to recover their spontaneous erections. That may be one of those scenarios where we're more likely to teach them to do self-injections of phenylephrine.
Yeah, just like a lot of guys are, they don't want to do home injections for their ED. They don't want to do home injections for their priapism. Okay. Go to the next slide here. So this is reminds me of a story. When I was attending back in Springfield, Illinois, I had a couple well-intentioned residents, and they were treating somebody with high flow priapism with irrigation, which is not the correct treatment. High flow priapism doesn't require treatment, first of all. But I went into the room and I was like, why is there blood everywhere? It's because they're like they're just pulling arterial blood out of this guy's penis. They're actually like doing a bloodletting.
Bloodletting.
Yeah, it's not. High flow priapism is not treated with aspiration and phenylephrine. That is treated with time. It's not an emergency. And then if it doesn't go away by itself, which it often does, then you can sometimes embolize the area. So, but this is sometimes what you'll get. You have to pull all this old blood out. And I would argue that this person has had like 8 too many vials pulled. These really dark containers, this was necessary. But these containers here, this looks like arterial blood to me. It's pretty bright red. Once you start getting this, you've won the battle. And the other thing that if you've won the battle is if you start to see changes on the monitor when you give phenylephrine. Now, you can sometimes get reflex bradycardia, so you can decrease their heart rate. Sometimes you can get a tachycardia. Sometimes you can get hypertension. So if patients are peds patients or they have a heart history and we give phenylephrine, we need to monitor them if possible, right? Because we don't want to give them a heart attack, either from the stress of the situation or the fact that we're giving them a brief hypertensive crisis or making them bradycardic from the medicine. But once you see changes based on giving the phenylephrine, it's getting to their intravascular system, and at least temporarily we fix their priapism because now the medication is getting beyond the penis where it was trapped before. If you give that stuff and you see no budge in the monitor, it ain't getting to the systemic system. It's probably not helping. And you do often see this, sad looking hematoma penis. And yeah, the penis really takes a beating. And when you do this, there's often pain independent of whether or not you fix the priapism. It just changes the nature of the pain from that of ischemia to one from like getting hit with a hammer or something. All right, next slide. So is this one yours, Matt? I can't remember. You take it.
I'm happy to take this one. All right. So this is essentially talking about how we, what we would do to prevent needing to take someone to the operating room for some type of surgical management. So we've already kind of gone through some of this, right? So patient comes in, history and physical examination are suggestive of ischemic priapism. You get a blood gas and it suggests ischemic priapism. Start with the intracavernosal injection of phenylephrine, and then ideally, if you're able to, do the aspiration of the that crank oil as well. We need to be focusing on the penis as opposed to those systemic treatments. So your Sudafed, your nebulizer, your ice packs, those things are fine, but they shouldn't take, they should not get in the way of you moving forward with the most definitive treatment. And we talked about this, phenylephrine, definitely the agent of choice as opposed to some of the other alpha agonists or sympathomimetics based on comparative studies. And this is consistent with the previous guideline as well. So this should be the agent that we are using in the treatment of priapism, whether in the office or in the emergency department.
All right. So now we're going to move into like some surgical information, which may or may not be of interest to you. But essentially, when we're talking about pre-surgical, remember aspiration irrigation always better than just aspiration irrigation with the injection is always better than aspiration irrigation alone. And then, shunt surgery is a way to now divert, to create an artificial opening between the normal penile tissue where the blood is stuck and a different escape mechanism. And so when you do combination therapy and shunts, it's more effective when you do the other thing. So when you're diagnosing with imaging, I'm going to quickly go on this slide, and we're a little pressed for time, but we don't have that many slides left. I want to get finished here, so everybody, I respect everyone's time. Diagnostic imaging, again, if you need it to help make the diagnosis, get it. But especially a high flow priapism doesn't need to be done emergently, and MRI is unlikely to have a role in the initial diagnosis and treatment phase of the priapism. We kind of covered this slide already, covered that one. So this is a very interesting slide, Matt, if you want to look at this. I don't know if you've seen this data before.
Yeah. No, this is a frequently cited study that came out of Memorial Sloan Kettering, essentially looking at patients who presented with ischemic priapism and trying to predict the likelihood of recovery of erectile function based on the duration of their priapism. And these are patients who didn't undergo a shunting procedure, so they underwent aspiration and irrigation. And essentially what they found is that patients who came in with a priapism duration of less than 12 hours who were treated per guideline recommendations, essentially all of those patients recovered their erectile function. Whereas when you get out to 24 to 36 hours, it was less than 50%. And beyond 36, and this is where that question stem came from, beyond 36 hours, the likelihood of recovery is essentially zero. So then our goals sort of change at that point, right? At that point, the goal is pain management. I mean, it's still important, but the likelihood, and we need to counsel our patients about this, the likelihood of recovering spontaneous erectile function goes down drastically beyond 24 to 36 hours.
All right, so kind of review again. You monitor blood pressure and heart rate, especially in patients at risk for heart attacks and PEDS patients. Occasionally you get these young patients that have, bone cancers, leukemias, lymphomas, these type of things. And, you're giving them phenylephrine to help reverse some of these cancer-induced priapisms. So surgical management. So after the injections fail, then you get to start to do shunt surgery. And we're gonna fly through these because they're not as applicable to the APPs. But essentially what we're doing is trying to create an artificial opening, and there's different kinds of shunts, right? There used to be a kind of dichotomy of shunts, like the distal shunt and the proximal shunt. And the distal shunt can sometimes be done in the emergency room and involves we're going to show you some pictures here in a second, involves creating opening of the distal penis into the glans penis, which is a good escape route. And the proximal shunts used to try to like connect the corpora to the urethral corpus spongiosum, or use like some kind of crazy vein graft, which sounds cool, but like is very difficult to do and takes 8 hours. And so the new guidelines for the surgical side of things basically says don't do proximal shunts anymore. They're kaput, they're gone. And instead we do more aggressive distal shunts, which we'll get some pictures of. So the goals of shunt surgery: resolve pain and try to reoxygenate the tissue. How do you do that? Get blood to flow in there. And keep in mind that when you put a penile implant in, you do resolve the pain, you do treat their erectile function, but it isn't the natural function, right? You're not reoxygenating the tissue, but you can't reoxygenate a tissue that's already dead after 36 hours. So that's why we think about penile implants earlier than later in some men in the right situation. So why don't you take us through some of these shunts, Matt?
Okay, so there are several different types of distal shunts. And again, the goal here is to create a connection between the cavernosal body and some other tissue so that that blood can go back into the systemic system. And so here that's cavernosal body and spongiosum. And so we have my 2-year-old sneaking into the room on us, sorry, smiling as he does it. So essentially this algarob, we make an incision on the gland's penis and excise a piece of the distal corporal body so that there's now a connection between the spongy tissue in the glands and the corporal body. And then we sew that up, and blood can then, as we can see on the lower picture, follow that pathway into the spongiosum and back into the systemic system. So this is probably one of the more definitive distal shunts that we can do. These ones tend to be done in the operating room.
We had a question rolling in. What would be the main guideline or sexual rehabilitation of recovering sex life after ischemic and non-ischemic priapism? So that's a good question. If you treat the priapism very quickly, there's probably not much recovery. It's going to work just fine. It's amazing. Sometimes you'll do these shunts and they'll get a recurrent priapism a month later. It's bananas. And obviously, if they're getting another priapism, it still works for sex. So not much recovery to do. If you have a significant prolonged priapism episode, you're probably going to need a penile implant. And so before we do that, sometimes we'll have them use a vacuum device to help stretch the tissue to condition the penis for a safer surgery. Non-ischemic priapism still works for sex. And so they don't have to do anything. But if they want to treat the non-ischemic priapism, they'd get it embolized with a CT. But non-emergency, wait months. Hopefully it will resolve on its own. Sometimes it does. Sometimes you can use hormones to make that happen too. All right, this is another way to do a distal shunt is to, and this is the most common way these days for distal shunt, is you stick a scalpel in the head of the penis, and that's a kind of Tom Lou shunt, and that creates an opening. But not only that, we actually stick an instrument the whole way down to open up a chamber so that new blood can flow in and through the escape mechanism. So this tunneling or the snake maneuver is something we do when there's severe priapism. We'll put a shunt in by sticking a scalpel in there and then dilating down. So here's a better picture of the T shunt. And this is my favorite thing, my favorite shunt to do if it's going to be done in the emergency room. You do a penile block, put a catheter in, take the cello bow 10 blade, and then you stick it through the glands. Try not to hit the urethra. You spin it out laterally and you pull it out. Thus you make a T-like defect. Then you like milk the penis and arterial blood starts shooting and hitting the ceiling. So then you need to use like a running locking 5-0 chromic to close up this defect. But now the blood is coursing from the glands into the corpora and vice versa. And that allows the escape of blood. And this is really effective. And if you combine this with tunneling, like we do for a penile implant, when we try to prep the corpora before we put the device in, it works even better. All right, so there are no studies comparing tunneling with or without, shunts with or without tunneling. Again, kind of surgical nuance. Basically, surgeons can sometimes opt to tunnel, and they typically will do it more aggressively if it's been a longer duration of priapism. I'm going to skip that slide. Post-surgical changes is kind of an interesting slide. Why don't you talk about this one, Matt?
All right. So, this is essentially is a scenario where one, you want to know if you have persistent ischemic priapism or if that penis is swollen. as a result. So, you do a shunt, you're creating a high flow priapism from a low flow priapism. So in that setting, you may have some tumescence, you may have some swelling of the penis, and this is where either a corporal blood gas, although that can be abnormal for a period of hours, or a penile ultrasound can help us differentiate. So, it's very common that I call myself Paranoia Pete. I'm getting a penile ultrasound the next morning to just make sure that my shunt actually worked. For patients where you're concerned that essentially they have irreversible tissue ischemia or necrosis, essentially, that's where an MRI would have a lot of utility. And this can be useful as you're thinking about subsequent treatment planning. Is this a patient who you want to get ready for an IPP and move down the insurance coverage pathway? Is this a patient who, if his pain's controlled, you don't even need to move forward with these shunts because there's already evidence of significant corporal necrosis, and that's where the MRI can be useful.
Very good. So there's this concept then, if we have 36 hours of continuous priapism and we know that their penis isn't going to work, but they're interested in having sex in the future, well, you can put a penile prosthesis in, right? And the question remains, well, should I do it right now when the guy's admitted to the hospital, or should I wait a little bit, or should I wait 6 months before I do it? Turns out, I'll make a long story short, that you can do it in the immediate setting, but it's very impractical to do that in the United States because it might not get paid for by the insurance company. In England, they routinely will stick malleables in at the time of admission because it's paid for by the healthcare service there. So it just depends on what country you live in. In the US, it turns out it's safe to wait about 3 weeks after a severe priapism episode and then put the penile implant in. And that kind of helps. If you wait 6 months to try to put a penile implant in, it's a disaster. It's like concrete, and the surgical complication rate is 10%, even for the world's expert penile implant surgeons. It's a nightmare. So we never want to wait that long. If you put it in immediately upon the first admission, you're not only dealing with the insurance coverage of the device, but a person has just been sticking a needle inside this penis like 20,000 times. It could be infected. It's got hematoma. The tissue is garbage. And so it's better to kind of let things calm down. It can be kind of pseudo-infected, right? Because it's not exactly the most sterile process. You have needles flying in and out constantly. So it's better probably to wait about 3 weeks if you're going to put a penile implant in the United States. And that's kind of an optimal timing because there's no scarring of the penis over those first 3 weeks, but things can calm down from the initial admission and you can get it cleared with the insurance. All right, so we're to our summary slides, and I think we're doing good for time. So 3 minutes left.
Okay, so just to reiterate some of the important take-home points, and again, feel free as we're closing up here to put any last-minute questions in the Q&A. So acute ischemic priapism is absolutely a medical emergency that requires a multidisciplinary approach. It should involve urologic specialists, including all those on the call here tonight. So the fact that you're here learning with us how to optimally manage this patient is important. There are new techniques that have been adopted. So this guideline that came out last year has important updates, and certainly would refer you all to AUA.net, and then there's a guidelines tab to read the full guideline. It's very user friendly. I just read it last night in preparation for this discussion. And as we have discussed, management of ischemic priapism is empiric, meaning that we're basing this on the available data we have. We're basing this on clinical experience, but ultimately that treatment pathway should be followed because it works. We need more studies essentially to help advance this field, as we do in most areas of medicine. So.
All right. Well, with that, we're going to close things down. If you have any last minute questions, you have 1 minute to put it into the Q&A. Otherwise, you will have a burning question for the remainder of your life. Thank you so much for listening to us blather on for a bit. Here are our Twitter handles. Please follow us if you so desire. We're both here in Rochester with the Mayo Clinic Men's Health Program. A tremendous amount of thank you to the SMSNA and Endo for letting us do this. And 3 questions have rolled in. Oh, maybe not. Some thanks. Thank you. Is there CME for this meeting? I do not know.
It's a
I
great
don't think.
question.
Yeah, I don't know. There should be if there's not.
We'll have to get back to you on that one.
Yeah, we'll definitely have
man.
to get back to you. And this
Yeah.
is watchable in the members only section of the SMSNA, along with all the previous lectures from last year and all the forthcoming lectures this year. Endo has done a tremendous job of helping support APP's education along with the SMS. And we're so happy that you spent some time and joined us. And I hope you got something out of it.
Yeah,
And
thanks
absolutely,
everybody. The one thing I was going to say too is, we didn't get a chance to talk about stuttering priapism tonight, but so if you, that's a tough one, right? Dr. Kohler and I were both talking
yeah,
about some challenging patients just yesterday. So if you have questions, you have a difficult case, you want to talk through with somebody, shoot us an email, and happy to review those with everybody.
absolutely. And there are going to be new guidelines out addressing these very tough questions with the best evidence we have. In general, the evidence is pretty lousy, but we do the best we can, and we'll go from there. All right. Good night, everyone. Thank you for your attendance. Really appreciate it. Bye-bye.